Tonight, what I'm going to do is to try to give you a much more in-depth understanding of one of those three main areas that our lab does testing for, and that is saliva hormone testing. This is what we started with a good number of years ago when we began our lab in Canada, and has remained an important part of the services that we offer. And so I'm going to dive right in and try to give you a really decent idea, I hope, of what saliva hormone testing is all about and how we actually approach it. For those of you who already do saliva hormone testing, there may be some pearls that you'll get from this that you'll be able to look at. But I think that in order to really understand why saliva, we really need to understand that oral fluids in general have begun to be called the mirror of the body, because it really reflects the levels of fluids, the molecules that are introduced for therapeutic reasons and various other reasons. It is able to give you a pretty good understanding of the emotional status of an individual, their hormonal status, which we will discuss this evening, as well as other things like immunological, neurological, and of course, nutritional status, and the effects of metabolic influences. The whole area of metabolomics is now becoming a very, very active thing in the area of saliva. And I think in order to look at saliva, you always need to be reminded of how that relates to what goes on in the two other main fluids that are being used. One is blood, and the other one is urine. And so I want to remind everyone that blood testing, which of course is a standard and a gold standard for many types of tests, and is done by physicians almost exclusively, they do blood testing. It tells you what the total levels are of a particular entity, in this case, the various types of steroids, but it can be modified by proteins that bind it. And so you need to understand that in blood, when you're looking at hormones, up to about 98% of those hormones are biologically inactive because they're bound up with other binding proteins. So that causes a problem in and of itself. Saliva, on the other hand, does not have that issue because the hormones that you actually test for are those that are free. It's also called bioavailable. And as I said, 3%, 2%, 4% is what you're really looking at. But those are the hormones that really can be utilized at any given moment in time by the body. Urine is an interesting area because you have both wet urine and, of course, dried urine, which has become more popular of late. And one has to be a little bit circumspect when you talk about that, because you need to be very careful about, number one, what type of urine testing is being done. And if in fact it is dried urine, one needs to be very cognizant of the way it has been tested, the way the person prepared the urine, how they dried it, etc. But it is another one of the three major fluids. So as I said, with saliva, you're really getting a diffusion or an active transport of free hormonal steroids from the blood to saliva. And in the blood, which is on the left side, you can see that there are elements, hormones that are free, and most of them that are bound up. As I said earlier, they're bound up mostly with albumin, and some of them as well with what's called CpG, which is the corticosteroid binding globulin. In any case, these hormones are mostly bound up. But when they get through into saliva, either by passive diffusion or being actively transported in, what you're looking at, as I said earlier, is the free or bioavailable fraction. So saliva sampling then becomes an excellent medium for rapid testing because it can be done by an individual in their homes and it takes just a few minutes to be able to get enough saliva in a tube to be able to then send it to the lab. So it has the advantages of being a very accurate measure, actually, of clinically validated biomarkers. In fact, as time has gone on and as we've gained more experience, we now can say that it rivals blood in terms of the objectivity of the type of results that you're getting. Clearly, there's an ease of access. It's the mouth. You're just spewing some saliva into a tube. What could be easier? It's therefore non-invasive as a collection modality. So the sample really does not need you to puncture skin. And so it's very, very good. It's almost ideal for multiple or serial sampling, which is what most clinicians will use it for. And of course, because of the fact that you don't have to puncture skin, etc., it reduces the risk substantially of any kind of disease transmission. And because of that, it is gaining and continues to gain increased acceptance by patients to this day. Now, what we're going to be talking about is not conventional testing, which is on the left. So there you're looking at ACTH, TSH, free T3, these are thyroid tests and so on. That is not done in saliva. What we're looking at is the complementary, or what we can call the wellness space type of testing, cortisol and DHEA, melatonin, and the various sex hormones, which we will go into in more detail in a few moments. And so one of the questions, of course, is why would you want to do hormone profile testing? What would be some of the reasons? Well, one of them is very clear, and that is that you want to test adrenal function, which is really testing for the stress hormones. You really want to get an idea of how well that individual is dealing with stress, and specifically cortisol and DHEA. That's an extremely important part of saliva hormone testing. The other aspects here, anovulation and fertility, premenstrual syndrome and osteoporosis are all important, but they really pale in comparison to testing for stress. And so this is the classic pathway that you have probably seen before. A lot of people will keep that in their drawers in the office, so they'll be able to be reminded of the pathways. But what you do need to keep in mind is that the story begins with cholesterol, which will create pregnenolone. Pregnenolone is the precursor hormone. It is the mother hormone, which then goes on to create all of the hormones that we're going to be discussing this evening. One of them, of course, is progesterone, one of the sex hormones, which eventually can create cortisol, and of course can go on to cortisone or aldosterone. And pregnenolone can also form DHEA, which is another one of the adrenal hormones, which we'll discuss in more detail in a few moments. And from that, you can create testosterone or the various types of estrogens, specifically estradiol, which is the most important one that we'll be discussing, but also which is E2, E1, also known as estrone, and estriol E3. Estrone during pregnancy, estriol postmenopausal, but the most important one is estriol. And so let's take a look at adrenal stress and what one can do with that. Excuse me for just one moment. We're going to get a quick look at the three different things that you can be looking at. The classic first one is adrenal stress testing in general. Why are you testing for it? Well, you want to deal with the issue of people who are under stress, and you want to know how they're coping with that. What happens when you have fatigue or low energy? What about people who are gaining weight in their abdominal area or have sleep disturbances or, in fact, insomnia? What about people with anxiety or depression? Or, very important, have various blood sugar imbalances? What do these particular hormone tests tell you about that situation? So let's take a look at diurnal cortisol. And diurnal cortisol is looking, of course, at what cortisol does. You need to understand that cortisol, which you see here in red, and it's on the x-axis, will go through its highest level right at the beginning of the morning when you get up, and then will have a decay over the day until you go to sleep, where it reaches its lowest levels and then begins to really start to replenish during the night. This differs from melatonin, which we'll discuss a little bit as well, which actually is replenished in the middle of the night and then drops precipitously while you're still sleeping, and then goes down to an extremely low, flat area, only to begin rising again towards the end of an evening, and then to exponentially rise again when you fall asleep. But the two of them are extremely important together. Specifically melatonin, which I did want to mention for a few moments. I think it is important to mention it. Melatonin really is a multifaceted hormone. It is an extremely powerful antioxidant, and many of you may not be aware that it is a key antioxidant. It is a product of tryptophan, which is produced not only by foods, but a very large number of species of bacteria in the microbiome in the gut. Tryptophan, of course, as we know, will create serotonin, which is one of the neurotransmitters. In fact, 70 or 80% of serotonin in the body is really produced in the gut. But what you also have tryptophan creating is melatonin. And in fact, serotonin itself can also create melatonin. And melatonin, we all know, is extremely important in regulating our sleep cycle, the circadian rhythm, the daily cycle of sleep. That is well known. What is less well known is that it's also very important in chelating of transitional metals, iron, copper, etc. It is a very powerful antioxidant and is involved in what happens with age-related neurogenic disease, male fertility, and its regulation of gastrointestinal motility. It is a very powerful local anti-inflammatory compound in the gut. So apart from its effect on sleep, which I mentioned earlier, please keep in mind that it has a very important function in the gut. And even more important than that, its major antioxidant effect is its protection of the mitochondria, the energy portion of the cell. In fact, it scavenges free radicals. And more than that, it upregulates or increases the level of glutathione, which, as you know, is a key element in creating antioxidant effects in the body. So if you get good circadian rhythm, that will decrease oxidative stress, whereas if you have disruption, chronodisruption, meaning sleep disruption, that will cause an increase in reactive oxygen and reactive nitrogen species. In other words, you will end up with problems of oxidation that will require antioxidant effects. But let's get back to cortisol. So normal cortisol, as I said, has a diurnal rhythm, and it has the classic diurnal curve, as you probably have seen, and the morning level is the highest, and then it goes down during the day. And so you will get elevated levels when you have hypercortisolism, something that is causing increases in cortisol, or some kind of exogenous source of cortisol, whatever that may be in what you're eating, or environmental levels that go up. And of course, depressed levels with hypoadrenal function, Addison's disease, etc. You can have loss of that diurnal rhythm in what we call the classic three patterns. Pattern one is just a hypercortisol curve. It never comes down. It just stays up there. There is no diurnal decrease. And that is normally because there is some kind of an active stressor. Something is continuing to create chronic stress, which eventually will lead to pattern three. I'm going to stop speaking about two for a moment, which is in effect flatlining. In other words, it's hypocortisol, very, very low cortisol. The HPA axis in the brain is unable to respond during sleep. You get complete adrenal fatigue. This will occur as well with diseases such as Addison's disease, in which, of course, there is adrenal insufficiency. Pattern 2 looks like one, but is actually a little bit different. It's quite unbalanced. In other words, you start high, you might come down low, and then oops, as you come towards the end of the day, instead of continuing to go down, it starts to go up again. And that can, in effect, cause sleep disturbances. Quite often people who are in depressive situations will show that kind of pattern. And so we do know that stressors will create problems for the HPA axis. That's the hypothalamus and pituitary adrenal axis. So if you have emotional and mental issues, that is going to create hyperstimulation of the sympathetic nervous system, which will do what? It's going to increase the HPA axis response, which then increases ACTH, which is the entity that increases adrenal action, meaning increases in cortisol, which is released from the adrenals. And it's the same if you have dysregulation of metabolic function, glycemic function, causes insulin resistance. And again, the same thing leads to increased cortisol released by the adrenals. And that is the same thing with chronic inflammation and pain or sleep disorders. And with sleep disorders, you may want to remember that obstructive sleep apnea as a syndrome is something that we see in many individuals, and that will also increase HPA axis response, leading, as I said, to a cortical release by the adrenals. And one needs to remember, going right back to the days of Hans Selye 40 and 50 years ago when he developed this, the idea is that you go through 3 stages of chronic stress, where in the initial stage 1, as opposed to normal, in stage 1 there can be a hyper cortisol response, over stimulation, and very high levels of cortisol, which can continue for a certain amount of time, but after a while the system cannot continue doing that, and it starts to gradually go through a sort of under-responsive reaction in stage 2, leading eventually to a non-responsive or adrenal fatigue, which was the word or the phrase that used to be used. The adrenals just give up. They say we just cannot continue to do that until you finally reach adrenal failure, which one hopes that you're not going to see in your clients or patients. So elevated cortisols do have many physiological causes. As I said earlier, stress, various types of fasting and what that does to insulin levels, the inflammation and pain, which I mentioned a few moments ago, all of that is going to elevate cortisol. These are the main physiological causes. Other causes, which can be absolute elevations or relative elevations in the morning. What happens when you have elevated levels in the morning? Well, it can be due to blood sugar issues, insulin problems, just too much blood sugar. And so you're ending up with higher than normal levels of cortisol right in the morning. Or it can be relative. You have pain when you're walking, when you're running, when you're making any movements. You're very stressed as you're waking up for whatever the reasons are, and that can give you a relative increase. It still seems normal, but then you drop down completely to flatline. So that is a relatively high level relative to the rest of the day. And there are a whole number of other issues. For example, what happens if you have elevated cortisol during noontime? Well, again, possible sugar, insulin issues. You may have skipped breakfast, so you're really pushing the issue from the morning into the area of noon. Or you have a late breakfast. You may actually be eating something and having a brunch for all that matters. And so the noon collection may look normal, but then you start elevating in the PM around 3, 4, or 5 o'clock. That should not be happening. So that tells you there is a blood sugar problem that's probably happening. But what happens if it's elevated throughout the day? As I mentioned earlier, that is normally due to some form of anxiety, some syndrome in which anxiety is a part of it, very high stress levels. People who have fibromyalgia and have those pains related to fibromyalgia will show this kind of pattern. And if it's very high throughout the day, very unusual, but that can be due to a whole number of issues, everything from contamination right through to, one hopes not, but it could be due to Cushing's syndrome or Cushing's disease, both subclinical and clinical. And if you remember, Cushing's is a pituitary tumor or something like that that is causing too much cortisol to be produced. And if you just have a single high value, something may have happened. There may have been high stress during that part of the day. You might have been doing very heavy exercise, etc. So it's normally stress induced, and that's the case. And low cortisol, of course, as I mentioned earlier, is due to the effects of chronic stress, where the system, the adrenals, in effect, give up. And in some very infrequent or rare cases, it can be due to very fulminant adrenal insufficiency, like Addison's disease, which is classic primary adrenal insufficiency, or corticosteroid overuse. All of this will cause a flat line. That is not a good sign. That needs to be dealt with. And the only way that you can really tell that that is happening is you've got a test. There really is no other reliable way. That was a very quick way of looking at cortisol. What about DHEA and DHEA S? Well, if I reminded you a little earlier, DHEA is a common pathway for a whole number of the sex hormones, and we're going to take a look at both DHEA and DHEA S, which is the sulfated form, and I'll have a little bit to say about that in just a moment. DHEA is the most abundant form of these steroid hormones in the body. So it's produced by a whole number of different organs, the adrenal cortex, of course, the testes, ovaries, brain, etc. As I mentioned earlier, it is the precursor of the sex hormones. It's an antagonist to cortisol. So when cortisol is high, DHEA will quite often drop, and vice versa, like a seesaw. With aging, you lose that diurnal rhythm in the elderly, and suboptimal levels of this are seen with people who have the various chronics, IBD, the various inflammatory diseases, rheumatoid arthritis, and a whole number of mood disorders, or people with chronic pain, like chronic fatigue syndrome, fibromyalgia, which are quite ubiquitous in our society. Both DHEA and DHEA S do decrease substantially with age. They're down to about 20% of their levels when you're in your youth by the time you reach the age of 70. And so the result of that is a decreased capacity of the sex hormones to protect brain function. And I'm going to remind you, as I will later on, that one of the effects of the sex hormones is to protect the brain. The brain, therefore, has a greater susceptibility to some of the neurotoxic effects of cortisol, which normally would be balanced by the sex hormones and DHEA. So you need to remember, when you talk about DHEA S, the sulfated form, 98% of circulating DHEA in the bloodstream is in its sulfated form. It's bound up with sulfate. In the same way that, as I mentioned, cortisol is bound up with albumin, etc. It's the same with this. So there is a close correlation with symptoms of various types of androgen deficiency and excess and what you see with DHEAS. So the result being bound up means that it's cleared much more slowly from the circulation. You don't have the types of day-to-day variant DHEA itself, and it does not give you a strong diurnal rhythm. And therefore, that's very good when you're testing, because you can get some pretty stable responses with DHEA S, and not to worry that it's bouncing all over the place during the day. It does not do that. So that DHEA, which is the non-sulfated form, that reflects the response to acute short-term stress. And as I said a moment ago, DHEA S, the sulfated form, is a stable indicator of long-term stress, and therefore it is the ideal test if one wants to understand the body's store of DHEA. You will get that by actually testing out DHEA S. And so when you have elevated levels of DHEA S, what you want to do is to rule out problems that will raise androgen levels, because remember, DHEA is a precursor of testosterone, etc. And so in females, you will find that with hypothyroidism and with the classic PCOS, which is polycystic ovary syndrome, which many of you are aware of. If not, remember that consists of a whole number of things, from various menstrual periods that may be heavy, excess body weight, facial hair, acne, and a number of other things, including patches of thick or darker velvety skin. It is part of what you see with non-classic congenital adrenal hyperplasia, and you'll see it with tumors. You'll see it with tumors like Cushing syndrome, which I mentioned a moment ago, is a pituitary tumor issue, and you'll see it in people with acromegaly, and so on. If you have low DHEA S, that's normally due, as I said, to chronic stress, which begins to really shut down or to decrease the ability of the adrenal cortex to produce any of these hormones, and that is a problem. It will also happen during menopause and also during andropause in men. And of course, in more rare cases with Addison's disease, which again I'm reminding you is adrenal insufficiency. And last but not least in this grouping is the adrenal check. Just to remind you that when you do an adrenal check with the Fluids IQ, we show you not only the 4 cortisols, but together with DHEA S, so you can look at the ratio of the two, and that's an indicator of HPA axis function and the classic indicator of adrenal output. So if you have chronic stress, you're going to get more pregnenolone in the adrenals, that's the mother hormone, and with a lot of stress, it's going to overproduce cortisol. You, in fact, get what's called cortisol escape, which is a dramatic increase in cortisol being produced by the adrenals because of chronic stress. And because of that, they're going to underproduce DHEA in many cases, as well as the sex hormones, because it is so busy trying to produce cortisol that it cannot produce the others as well. And so because of that, you get an elevated cortisol to DHEA ratio, which means that you have adrenal dysfunction. So you're able to identify HPA axis dysfunction, and because of that, you're able to refine the therapeutics, the way in which you are looking at what you can do for your clients or your patients. So when do you order an adrenal check? Well, one of them is clear: when you want to assess endogenous hormone levels, what's being produced by the body. You want to measure the amount of hormone absorption. You want to know, for example, in females using topical hormones, what is actually getting into the system and how much of that is usable. And of course, in some cases, when you're doing over-the-counter cream work with hormones, you can get contaminants and you can get an inadvertent exposure, and that happens more often than one would think. And so what you're going to get when you're working with Fluids IQ is you're going to get a report that looks something like this, where you get the 4 cortisols, the total cortisol, the DHEA S, and then the ratio of the total cortisol to DHEA S to give you what you require as a function of one versus the other. And in this case, as you can see, we have a person who has flatlined. So let's let's take a look then at the female parts of the panel, because as part of what we do, we also do what we call female wellness panels and male wellness panels. The female wellness is estradiol 2, the estrogen, progesterone, testosterone, DHEA S, and cortisol. And it's the same with the male, except we're not giving you progesterone, but you're getting all the rest of it. And so remember again that when we're looking at the sex hormones, we're looking at progesterone, testosterone, and estradiol. And just to remind you, for those of you who may not have seen it in a while, remember what happens during a typical monthly phase. The endometrial cycle will last normally about 28 to 32 days. And what you are going to get in the initial part of the phase, you get the follicular phase, and that is the increase or ripening of the follicles controlled by estrogen. And then you get a couple of days of ovulation, leading to the last part of the phase, which is known as the luteal phase. And that is the time when you're getting the ripening of the corpus luteum, which is where the egg is going to sit if it's fertilized and begin to form. Of estrogen, we know, and we're testing for estradiol or primary.
Dr. Aron, can you hear me?
He froze. Can you hear me, PJ?
Yes, I can hear you. Seemingly, Dr. Aron is disconnected.
I don't know. He seems to be on still, but
The screen is freezed.
Oh.
Okay, he disconnected right now.
He's connected, so he's probably going to join back.
Sorry, everyone, for inconvenience.
1 second. We'll just get him back on. I'm sure he'll. There he is. Aron, can you hear me? You're on mute.
Can you hear me now?
That's perfect. Yes.
Okay, thank you very much. I don't know when it disappeared, but let's hope that you heard everything up until then.
So just about 30 seconds.
Okay, so I'm discussing estrogens, and what I wanted to mention is that estriol, which is E3, it is the most plentiful of the three estrogens, but it's also the weakest. And you normally see it in its most abundant form during pregnancy. Estrone, which is E1, it's the primary form of estrogen in menopause. You don't see very much of it at that point. The one that is the strongest with the highest amount of potency is estradiol, E2, which, as I said, is what we test for. It's about 80 times stronger than estriol, just to give you a general idea. So that's the most important estrogen in non-pregnant females. And I just wanted to deal with high estriol because I think it's important to know that if you're premenopausal, the overproduction of estriol and androgens by the adrenals and the ovaries, DHEA and testosterone will occur, especially if you're creating estrogen replacement therapy, ERT, hormone replacement therapy. You will see this. In postmenopausal women who are taking estrogen supplements, you can quite often get excess estrogen levels even at normal premenopausal levels. And if it's not balanced by adequate progesterone, you will create what's called estrogen dominance, which some of you may be aware of. And this can be quite... I've written a whole number of things that it causes. There are about 14 or 15 main things which comprise estrogen dominance: mood swings, irritability, decreased sex drive, etc. You can read that in the PDF, which will be given to you, but it's an important entity which can happen with high estriol. Progesterone is produced in the ovaries, and as we know, it's very important for normal reproductive and menstrual function. And as I mentioned a little earlier, it is active during the latter phase or the luteal phase of the menstrual cycle, but it does have very important roles to play in the health of the heart, the skin, bone, blood vessels, etc. And as I mentioned, as well as the brain, and that is extremely important to remember. A low progesterone does have a role in females in abnormal uterine bleeding, and it will be associated with lower neurological function as well as osteoporosis. So that goes to what I mentioned earlier about the importance of progesterone outside its sex hormone function. And it's common in the following groups. Of course, postmenopausal women who are no longer ovulating, or those who had their ovaries removed, and of course those who are using contraceptives or hormone replacement therapy. Their endogenously produced progesterone goes down precipitously. High progesterone, of course, is, like I mentioned earlier, an important issue in people who have stress and anxiety states, and that is similar for men and women alike. And there are a whole number of common symptoms, which I'm not going to spend a lot of time on. But of course, the uterine bleeding I mentioned, if you go down below, decreased sex drive and the contribution to weight gain, etc., are extremely important. And there are a whole number of signs and symptoms of high progesterone, and there are clinicians that deal with this constantly, day after day. And so it's anything from breast tenderness, what I mentioned earlier about mood swings and anxiety or frank depression, loss of libido, etc. All of these are extremely important and are part also of PCOS. What about testosterone? I'm giving you a quick overview here. So if those who want more information, you can always give me a call and we can go through it in more detail. Testosterone is the male hormone, of course, is produced by the testes and is also produced in much smaller quantities by women in their ovaries. It is responsible clearly for the male secondary sex characteristics, and that would be the deeper voice, the hair on the chest. It contributes to a healthy libido. It regulates the immune system. I want you to remember that. Like all of these sex hormones, they are important in regulating the immune system, especially that part of the immune system that lies intimately attached to the intestinal wall. And low testosterone can result from any number of things. First of all, aging. As we age, there's less testosterone. And of course, if the testes are removed or the ovaries are removed, you'll get less testosterone, etc. If you're taking synthetic HRT, which is hormone replacement therapy, of course, the amount of endogenous testosterone goes down precipitously. And the common signs and symptoms of low testosterone are quite well understood. Chronically low testosterone in either sex, fatigue, decreased energy, of course, reduced stamina and sex drive, etc., loss of bone and muscle mass. And all you have to do is to watch American television, and they keep telling you to order testosterone. So a lot of that is true, but you have to be careful because one can get higher levels of testosterone than necessary, and that can cause problems in and of itself. And in men, of course, testosterone levels decrease with age, and it's very common to have those decreased levels after the age of 60 and above. And in women, testosterone imbalance can be associated with coronary heart disease, heart attacks, especially in postmenopausal women. But remember, the important thing to see here is women produce testosterone, and that you will see in the Fluids IQ lab result that we actually give reference levels for testosterone in women. Of course, it's much less than in men, but it is there, and that is not abnormal. High testosterone, of course, because of excess production by the ovaries, the testes, adrenal glands, etc. And of course, when you're getting exogenous or androgen supplementation, that can cause problems for the endogenously produced stuff. And what happens as far as signs and symptoms, I'm just going to say that in women, there's a loss of scalp hair, increased body and facial hair, and acne and oily skin. So remember, supplementation with topical testosterone at doses which are in excess of the levels that are produced by the ovaries, which is what ends up happening quite often when you get supplementation, can raise these testosterone levels well beyond their physiological range. And because of that, you will end up with these individuals having any number of issues due to high levels of testosterone. How do you check for that? You have to test. And so we have various hormone panels, as I mentioned earlier. And what you need to remember is that when we are testing for female wellness, we have 3 tests. Female wellness, which gives you all of this, but just 1 cortisol in the morning. Female wellness plus, which is 2 cortisols, 1 in the morning, 1 in the afternoon. And female wellness daily cycle, again, same thing, except it's 4 cortisols. It's the diurnal 4 cortisols, which you see written here. Otherwise, everything else is the same. And that is true as well for male. There's no progesterone. Everything else is the same for male wellness plus 2 cortisols, and daily cycle, which is 4 cortisols. And the last thing that I'm going to want to discuss is hormonal imbalance and the gut. I made mention of that earlier. I want to stress that these hormones have extremely influential effects on the gut. We're talking about cortisol, the estrogens, testosterone, progesterone, and of course the thyroid, which we do not test for with saliva, but is also extremely important. And there are some classic effects, hormonal effects on the intestine, which can lead to classically what we call leaky gut or increased intestinal permeability. Cortisol, for example, modulates inflammation, permeability, and the neurotransmitters produced in the gut. Estrogen is well known, estradiol especially, to modulate paracellular permeability. That's leaky gut because it functions, and it will modulate that. It helps in that sense. Testosterone, if you have a lack of testosterone, it will delay intestinal healing. That's well understood. Progesterone, by treating with it, you protect the intestinal lining from various types of macroscopic injury and from allowing albumin to extravasate and to actually enter into the body. And thyroid, well, if you have a lack of thyroid stimulation of both gastric and intestinal cells, that will lead inexorably to ulcerations, both in the gastric area and the intestines, and will increase into the disease slide. I just want to remind you that when you have the effects going on in the gut, one of the is cortisol, and cortisol feeds right back into the intestine. And one of the things that it does is it will affect the mastocytes, which are an important part of the innate immune system. They lie intimately connected to the intestinal wall in the payers or Peyer's patches. So it needs to stimulation by cortisol of the immune system. You're going to get a tremendous outpouring from the mastocytes of TNF alpha, histamine. These are very, very powerful pro-inflammatory. In other words, they will promote inflammation in a very dramatic way. And so cortisol does have, if the gut is sending signals up to the brain, the brain, through the HPA axis, will stimulate creation of cortisol, and cortisol is going to have a whole series of effects, which are modulating inflammation of the gut, increasing gut permeability, increasing our perception of pain in the gut because of its effect on pain receptors. It will modulate gut motility. That is, how is food and other entities being pushed out of the gut, how quickly and how well. And so it can therefore affect gut microbiota, and that will have an effect in altering brain chemistry. And because of that, the result of all of that is that you can end up with any number of problems in which cortisol plays an important part. You can get GERD, which, as you know, is gastroesophageal reflux. You can get peptic ulcers, greater amounts of them. It's a very significant factor in IBD and in IBS, as well as food allergies, etc. It will slow the normal small intestinal transit time. In other words, how quickly is food getting out of the intestine? And if it doesn't, then it's going to promote overgrowth of bacteria, which we know as SIBO, small intestinal bacterial overgrowth, and of course the famous leaky gut syndrome or increased intestinal permeability. And so finally, what then are the benefits of doing hormonal testing? And by the way, it's been around for decades and decades, and it is really one of the seminal ways in which one tests. Well, the first thing is that you get a specific assessment of the various dysfunctions or diseases, because it is able to determine the quantity of the analytes that you're testing. So you're actually able to see objectively what is there. And remember, we're not diagnosing anything, but we are giving you analytic results so that you can see what's really going on. The treatment, therefore, whatever that may be, is biologically based, which I would hope in 2021, one can agree that it should be biologically based. And so in that way, it can determine overall health risk. And you can assess the medical status of the individual, because it therefore can help determine a course of treatment for that client or patient. And one of the other things about that is that the client or patient takes ownership of the problem, because they're seeing these results. You show them the actual report. And so the test result stands for itself. It is not something that's being dreamt up. It is there, it's objective, and therefore allows you to have a much stronger way of being able to have that person adhere to some kind of a protocol. So we're transitioning from traditional, we have already transitioned, I should change this slide, from tradition to biology-based therapy. And one of the things that it can do for anyone who's utilizing this type of saliva hormone therapy, or for that matter, any kind of testing, is that it differentiates your practice. I mean, the patients are going to see a difference. They're going to appreciate that their healthcare professional is in the forefront of knowledge, that they are using objective parameters. So it is definitely, by definition, a practice builder, and it is able to have your practice become a regional destination for patients because of that. And the lab report, as I mentioned a moment ago, is an extremely important communications tool between you and the patient or client, their family, etc. And last but not least, in terms of liability, a lab report is a very permanent part of a patient or client record, which it is important to have, so that you are able to show, should you ever end up in a situation where you are being confronted with some kind of a liability issue, you have that in front of you. So the overall benefit is that it does create a higher standard of care for patients. And of course, it does allow the patient or client to increase their understanding of the overall value of what is being done in this kind of a comprehensive integrative care environment. So we know it's a new standard of care. Diagnosis, therapies, whatever they are in the midst of a revolution that's been going on for quite a few years now. And diagnostics and various types of therapeutics are based on scientific evidence and sound biological principles. And that is from Rhonda Page back in 1998. I'm still holding on to it because it holds just as true today, or even more so. So I want to thank you for this, for staying with me during this very, very quick overview